Good evening and welcome. My name is Judy Alperin. I have the pleasure, honor, and great distinction of being the Chief Executive Officer of the Jewish Federation of Greater New Haven. And I thank you all for joining us tonight on what I know will be a most informative topic. I just want to point out to everyone that the views and opinions that are shared on this panel tonight are those of the individuals themselves and not reflective of their employers, practices, or hospitals. And we want to strongly encourage you that should you have specific questions that have to do with your own personal health, that you consult your physician. Since the onset of this pandemic, the Jewish Federation has endeavored to do its very best to be at the forefront of supporting our community. And tonight's program is just another step in that process. And hopefully this will all come to a conclusion shortly, but in the meantime, we're here for you as part of one big extended family. At the onset of the pandemic, when we shifted to this virtual world, we have sought out every opportunity to support those who need us. And that began with outreach of phone calls to those who were at home to check on them and to deliver resources and services and food and medicines and things that they needed, to the establishment of a hotline for emergencies, to a masks program that was able to distribute more than 1.5 million masks into the hands of those who needed them throughout our great state of Connecticut. And now through our amazing collaboration with the Jewish Foundation that created the Maimonides Response Fund, which has raised almost $500,000 to support the most pressing needs that have been caused by this pandemic. And this type of work we will continue to do. We will be there for you, however you may need us. I want to just share that we were overwhelmed by the many, many important questions that were raised on this topic tonight. And our panelists are going to do their best to answer them within the framework of the program. There will be some time, we hope, at the end for some live questions, although we are going to focus on the questions that we had in advance. If we don't get to your questions at the very end of the program, I apologize in advance for that. And I think with that, you're not here to hear me, so it's now my honor to pass the baton to Dena Schulman-Green, who will lead us through the program. Dena.
Thank you, Judy, and good evening, everyone. It's my pleasure to serve as tonight's moderator. Just a little bit about me. I'm a Federation board member and a Wexner Fellow, and in my professional life, I'm an associate professor at New York University Rory Meyers College of Nursing. My research is about helping patients and families to manage illness in collaboration with their healthcare professionals. Our goal tonight is to boost everyone's health literacy around COVID-19 vaccinations and to hopefully prevent illness, so less for me to do. I do have two thoughts I'd like to share before we get started tonight. The idea for this program arose during casual conversations between Federation staff and members of the community. And Federation staff recognized the need for a formal way to help community members get their questions answered about COVID vaccination. This is the role of Federation, to be responsive to needs in the community and to bring the community together to address those needs. So I want to thank Judy and Amy and Sarah Holtz and everyone who enabled this program to happen for once again fulfilling the Federation mission in a way that will touch our lives and the lives of our families in a very personal way. My second thought is that the COVID-19 pandemic, of course, has been with us for many months, and finally there's a light at the end of the tunnel. And as always in such times, it's useful to turn to the Torah and the rabbis to guide us, and now is no exception. Rabbi Yehoshua ben Levi said, "Asur lehitrapot b'divrei Torah." It is forbidden to heal oneself with words of Torah. The literal meaning of this passage is that it's forbidden to think that merely reciting the words of Torah will heal us like magic. Prayer and study are incredibly important and helpful and therapeutic, and they must be translated into action. We are thrilled that so many of you have chosen to take action by joining this informational program tonight. And I hope that our learning and being together will in itself be healing for us. So let me now set the stage for tonight's conversation. We've divided the questions that we received from you into 4 categories. The what and why of the vaccines, including their safety, efficacy, and technology. The when and how, which will address distribution of the vaccines. The who, which will address questions around different populations getting the vaccine. And life after the vaccine, where we'll take a look ahead. We'll have about 15 minutes for each section. We are so lucky to have with us tonight an incredible panel of medical experts. These are people that many of you know and whom you trust, and we are so grateful to have them with us tonight. So I'd like to begin by asking our panelists to introduce themselves, and we'll do this in alphabetical order, starting with Dr. Avni Singer. Dr. Avni Singer, could you unmute yourself?
Can you hear me?
Yes, thank you.
Okay. Hi, thanks, Dena. I'm Dr. Joe Avni Singer. I'm a pediatrician in the community. I came here in 1989 to do pediatric residency, stayed for fellowship at Yale, and have been here ever since. My family's actively involved in Congregation Bethel Kesser Israel, and my kids went to Ezra, so I'm pretty deeply rooted locally, and just very pleased to be able to, help a bit with this panel. I am on the clinical faculty at Yale, do some teaching, and I'm a member of a practice called Child and Adolescent Healthcare. We have offices here in New Haven and in Woodbridge.
Thank you. Dr. Bannock.
Hi, good evening. I'm David Bannock. I'm an infectious disease doctor and associate professor of medicine at the University of Connecticut School of Medicine. In my role as an infectious disease doctor, I take care of patients with infections, including patients with COVID-19. I also am the hospital epidemiologist and the director of our infection control program at UConn Health. And that in that role, I oversee all of our infection prevention related activities and am one of the medical leaders for our institution in the COVID-19 vaccine rollout. So thank you for having me.
Thank you for being here. Dr. Kolodner.
Hi, how are you? I'm Greg Kolodner. I am a pulmonary, critical care, and sleep physician. I run the sleep medicine department here at St. Mary's Hospital in Waterbury, which is part of Trinity Health in New England. I also am one of the critical care attendings here, and been in the community about 20 years.
Amazing, thank you. Dr. Fleischman, could you go next?
Sure. Steve Fleischman. I am an obstetrician gynecologist here in the New Haven area. I have a clinical faculty appointment, associate clinical professor at Yale, and I also serve as the associate chief of our department of OB/GYN at Yale New Haven Hospital. I have a practice here in New Haven called Sound Obstetrics and Gynecology. We have offices in New Haven, Shelton, Guilford, and Essex. Locally, I have the honor and privilege of serving as the president of our federation right now, and have been involved with the Jewish community for a while now here, and excited to have you all on this town hall, and excited to be here.
Thank you. Dr. Green.
Hi there, I'm Dr. Stephanie Green. I am an infectious disease doctor as well. I have an appointment at Yale University, been here in the community for 20 years, been 4 kids, been through the JCC preschool and Ezra Academy, and been on multiple boards, and including a lot, and I've been on a lot of the COVID specific committees. So I'm very happy to be involved in this.
Thank you for being here tonight. And Mr. Mark Holtz.
Thank you. My name is Mark Holtz. I am the Senior Vice President and Chief Operating Officer at Waterbury Hospital in Waterbury, a fellow of the American College of Healthcare Executives. In my role as Chief Operating Officer, I'm responsible for emergency management. And because of that, I've been the hospital incident commander since the start of the pandemic. And a lot of that responsibility has been around with the hospital operations around PPE and treatments, and now really have been responsible as a team player in the distribution, obtaining and distributing of the vaccines. I also sit on a task force at the Connecticut Hospital Association of all of the other incident commanders from the various hospitals around the state. My involvement in the Jewish community has been for over 20 years in various roles, including board members of my temple and the JCC, and very happy to be here with this esteemed panel tonight. Thank you.
Thank you. And Dr. Ravski.
Good to see everybody here. Thank you for having me, and thank you for attending this webinar. I'm Norm Ravski. I'm an obstetrician gynecologist here in New Haven. I'm associate clinical professor at the Yale School of Medicine in the Department of OBGYN and Reproductive Sciences. I am the president of County OBGYN with offices in New Haven, Brantford, Madison, and Wallingford. And I have been a past president of Ezra Academy, and I'm a past president of the Federation. So it's good to see everybody, and I hope that this is as informative to me and you as it can be. Thank you.
So you can see what an esteemed panel this is. Thank you all again for being here. I'm going to start by asking Dr. Kolodner to provide some context for us of where we are with COVID-19 and how we arrived at this point.
Thank you. So, I'd like to go into how I work in the ICU and what that means for the sickest patients right now with COVID. So I have 3 main points. COVID is still killing people, unfortunately, of all ages and risk factors. COVID is still leading to many people having major health problems that are life-changing. And the best treatment we have now is still prevention. Our treatments are getting better, but our best treatment is still prevention. The basic biology of this is the virus is called SARS-CoV-2. This name comes from a pretty deadly virus that first came out in 2003, SARS-CoV-1, which had a very high fatality rate. And research into this virus started rapidly and continued even as the virus essentially disappeared in the human population, the original one from 2003. Because physician scientists know that every part of the history of infectious disease is episodic pandemics. Research persisted into this vaccination even after it disappeared. And this is one of the main reasons why the vaccine developed far quicker than we expected. So why is this SARS-CoV-2, which causes the clinical syndrome COVID-19, such a problem? We know that anyone can get very sick and even die from COVID-19, but there are risk factors for serious infection: age, obesity, diabetes, hypertension, kidney disease, smoking, immune deficiency, lung disease, and it seems to be more serious in people of color. But the number one clinical problem is that patients develop what's called respiratory failure. The virus gets into the lung tissue and starts filling the air sacs with fluid and crud from other cells. And it blocks the ability of the lungs to exchange oxygen, carbon dioxide. And then the inflammation can get so bad that the lungs scar down. We get acute respiratory distress syndrome, which is where some patients even require a ventilator, a breathing machine, to go on to survive COVID. This virus also attacks the blood vessels in the sickest patients. It causes blood clots, heart attacks, weakening of the heart muscle, strokes, kidney failure. It makes patients more susceptible to other types of infections. And all the things we have to do in the ICU to maintain people's health, which includes sticking them with tubes and catheters, all lead to potential complications. Even though we try to study this and refine ways to balance saving lives and avoiding complications, things do happen in the intensive care unit. So what's working right now in the sickest hospitalized patients with COVID-19? Steroids, dexamethasone, and other medicines like that are now given to essentially everyone who requires extra oxygen for about 10 days. And this reduces the chance of dying from COVID-19 by about 10 to 15% from before steroids. We would like it to be more, but this level, even 10 to 15%, saves thousands of lives. We're using new forms of oxygen therapy, most notably high-flow nasal cannula oxygen, which has prevented many patients from needing ventilators. In some places where the demand has been very high, some hospitals are struggling to keep up with the oxygen need, but most have been able to do this. We've been putting people before and after they need the ventilator on their stomachs for a period of time, which works to clear parts of the lungs at a time, but increases the amount of nursing and supportive care we need for these people. Using a mask before infection may actually help reduce your severity of disease because of how much virus you get when you're infected. And there are also outpatient treatments for less sick patients that are working to some degree. New research is going on all the time, but with other viral infections, it's a big challenge. So what are the consequences of COVID-19? What happens to these sickest hospitalized patients? They have long hospitalizations, 2, 3, 4, 6 weeks. And if they need a ventilator, unfortunately, about 50% of them still die in the hospital. Their lungs can scar down even if they survive. They require long-term oxygen, have weakness, permanent lung damage, and months of healing. They might need tubes placed in the neck, tracheostomy, and feeding tubes for some people that survive this, but they're so weak they need intense rehabilitation. Some people have kidney disease to the point where they need dialysis. Some people have thinking and memory problems, some from strokes, some from the traumatic experience itself and the medicines we give them. So, as I've said, unfortunately, it's still a deadly disease. It's still killing people of all ages and risks. It still leads to many new health problems that are life-changing. And that's what makes prevention so important right now.
Thank you. That's important background information for us this evening. Dr. Bannock and Dr. Green, I wonder if you might discuss the general goals and effectiveness of the COVID-19 vaccine.
I'm happy to take that question. As we've heard, that the impact of COVID-19 has been tremendous. Our country has been ravaged. Over 400,000 have died. And when we think about, how we're going to be able to battle a pandemic, there's really 3 ingredients. First, we need to be able to test for it. So we need to be able to identify patients who have the infection, and we have to be able to isolate them to prevent them from spreading infection to others. Number 2, we need to have effective, what we call non-pharmacologic interventions that will help prevent the spread out in the community. So things like masking and physical distancing. And then number 3 is we need an effective vaccine. And fortunately, as of today, January 21st, 2021, we have 2 that are already readily available to us. And that's really important. And we have others that are coming down the pike. And if we have time, we can discuss them as well. But we have 2 effective mRNA vaccines, and we'll hear a little bit more detail about those. But when we think about the impact that vaccines can have, I think there's really 2 different ways that we need to be thinking about it. Vaccines prevent at the individual level. So we know these vaccines are highly effective. They prevent individuals from becoming symptomatic and sick from COVID-19. And just as importantly, they are extremely effective in preventing severe illness to get to the point that Dr. Kolodner had discussed with his patients in the intensive care unit. So these are very effective vaccines, and we need very safe vaccines. And these vaccines have excellent safety profiles, and we'll talk about that in a little bit more detail as well. But the overall goal here is to really prevent illness among individuals, and that helps prevent individuals from becoming sick, even dying. Also protects our hospital capacity to take care of patients with non-COVID related illness. So when our hospitalizations rise from COVID-19, that really limits our capacity. So we have to be able to be prepared as a healthcare system to be able to take care of all of our patients. And then beyond the individual benefit, there is a benefit of vaccinating in terms of what we call herd immunity or the community level immunity. So if enough people in the community become vaccinated, that'll be really what we need to drive down the overall amount of virus that circulates in the community. And that will protect everyone, all of those who are vaccinated, even those who may not be able to be vaccinated from becoming sick. So really, we have an obligation as individuals to protect ourselves. We have an obligation to protect those around us, like our family and our friends. And we have an obligation to protect the larger community by driving down that rate of SARS-CoV-2 virus circulating in the community.
So many important reasons why people should get vaccinated. Dr. Green, could you talk to us a little bit about how the different vaccines work?
Yeah, sure. I can definitely tackle that. So, as Greg and David had said, that vaccines are an important part of our toolbox. We have lots of different tools like we were talking about. There's personal protection and social distancing, but vaccination is really important moving forward and how it's going to get us out of this pandemic. I just wanted, for those of you who don't know, but there's two awesome websites. One is the New York Times and one is the Johns Hopkins Corona Resource Center. Both of those are really good at tracking COVID cases and actually tracking the progression of how we're doing on the vaccine front. Right now there are 68 vaccines that are in clinical trials in humans, which is unbelievable. 20 of those have gotten to the late phase, which is what we call phase 3. And we have more than, I think, 90 that are being studied in animals. There are lots of different kinds of vaccines, and they all kind of work a little bit differently, but they all have the common goal, which is making an immune response so that we could recognize the infection in the future. There's lots of vaccines. There's killed vaccines, we call, or inactivated. There's attenuated or weakened. There's protein-based, and then there's the newer technology, which is the mRNA technology that I'll talk about in a little bit more detail, and also what's called viral vector technology. Essentially, both the gene, mRNA gene and the viral vectors are just ways to get the gene into our cells, and so that the cells can actually respond to it and make antibodies. So specifically, I wanted to dive a little bit deeper into the mRNA vaccine. If we all have seen the picture of the SARS-CoV-2, which is the virus, and it has those little club-shaped spikes. Those are called the spike proteins, and those spike proteins are what allow the virus to get to it attach to our healthy cells and infect and replicate. So that's the target of most of these initial mRNA vaccines. If you look inside, there's single-stranded RNA. There's DNA and RNA. They're in this particular virus, it's RNA. And what they've done is figured out the little portion that encodes this spike protein, and they've synthesized it, and it's called mRNA. And they synthesized it, and because it's unstable at room temperature, they've surrounded it with these oil bubbles that it's called a lipid nanoparticle little layer, and it creates these molecules, and that's really the basis of and the foundation of the vaccine. And so once injected locally, these lipid nanoparticles kind of bounce around and they fuse, they find our cells and they fuse, and the mRNA gets inside that our healthy cells, and then our own host machinery kind of takes over and makes lots of different copies of this and creates these spike proteins, which eventually kind of float out to the surface. And then our immune system can recognize them as being foreign. And that's what stimulates our B cells and T cells and what leads to our immune response. So there's other, if we have time, there's, we can talk a little bit more about the viral vectors because those are kind of the next in the pipeline. But I think the two big ones are the mRNA vaccine.
Great. So there are so many questions I could follow up with. We have just a few more minutes in this segment. So let me just ask for kind of shorter answer questions. Does the vaccine work on the mutated strains of COVID?
So I can take that one. So you may have been hearing that we've identified variants or mutated strains of the virus. And those are, just like Dr. Green alluded to in terms of the structure of the virus, those little spike proteins. They're mutations that affect different parts of that protein that stimulates the immune response and that the body can respond to in fighting off. Fortunately, when we see individual mutations, they affect individual proteins. But the way that the vaccines work is they stimulate the body to produce what we call polyclonal antibodies. So these are antibodies that don't just target one part of the protein, but they target many different parts of the protein. And that allows them to, these vaccines to generate an immune response that can be effective even against strains that do have mutations in them.
Mm-hmm.
And the strains that we've seen so far have had isolated mutations, maybe a few mutations. But with those strains, there isn't concern that the vaccine won't be effective. The vaccine should still hold up to be effective. But it is something that we have to constantly be monitoring for. And if we see more and more mutations accumulate over time, we may need to revisit that. But at this point, there's no indication that the vaccines wouldn't be effective against the circulating variant strains that are out there in the community.
So that's very reassuring. Can someone still be a carrier of COVID after they've been vaccinated?
So that's a really important question and one that we're learning more and more about. So as I mentioned earlier, we know that the vaccine is very effective in preventing people from developing symptomatic disease. But the question is about people who are infected but don't have symptoms. So we know a little bit about this. In the Moderna trial, they collected data on this information and showed that even after the first dose of the vaccine, the group that got vaccinated had a much lower rate of asymptomatic carriers. But that's a limited amount of data, and we have to recognize that. So this is an area that we're still learning more and more about. That being said, there's a lot of optimism for a few reasons. So we know that individuals who do become asymptomatic, never develop symptoms, are less likely to transmit the virus. So even if that does happen, that asymptomatic carriers or people who receive the virus can become asymptomatic carriers, it doesn't seem like they're at very high risk of spreading the virus to others. But until we have more and more data on this particular topic, we're still going to be adhering to those other preventive measures, including things like wearing masks and social distancing and avoiding those high-risk activities. Because for a few reasons, first, we're trying to get to the point where we have enough people vaccinated in the community that we have enough community-level immunity to ensure that we're all protected in case there is some asymptomatic carriage. And also, it'll help us drive down that overall rate of virus that's circulating in the community. So until we get to those points, we're going to stick to those preventive measures, wearing the masks, and eventually over time we'll get there to the point where we can loosen those up a bit.
Dena, can I just add something?
Yes, quickly.
2 points. Yeah, I'm sorry.
It's a lot of wonderful information. Thank you.
we get a lot of questions about this, but the little genetic material is not live. So you don't have to worry about catching COVID from the vaccine itself. And also the genetic material, the mRNA, is totally destroyed by our own cells in a couple days. So you don't have to worry about, there's no leftover trace of the coronavirus. So thank you.
Yes, important to know. Thank you. And so let's just wrap up this portion. Let's go back to Dr. Kolodner. And our question is, what effect you anticipate the vaccine distribution to have on hospitalization rates and intensive care unit capacity?
Well, I think we're already seeing a slight drop in the amount of nursing home patients in the local area as many nursing home and facilities have started to receive the vaccine. But I think there's three main problems right now: that we have a current capacity difficulty in getting everybody into the hospital at the same time because of the extra COVID patients. We have a backlog of people who have delayed healthcare either because they've been concerned about getting to the hospital or they can't reach their doctors, their primary care and outpatient doctors, because they've been closed or partially closed for periods of time this year. And there's also a little bit of staff exhaustion going on with nurses, doctors, PAs, respiratory therapists, pharmacists, lab technicians that we need to relieve. So, I mean, I think we're very hopeful about things, but we can't let our guard down. This vaccine is rolling out in stages because we need it and we don't want to create surges.
Thank you. So I'd like to move to our next category, which is the when and how. And we are so lucky to have Mr. Holtz with us with his perspective on distribution. So could you speak to us about vaccine distribution? There are so many moving parts. It's very complicated. Can you discuss how the vaccines get from the companies making them into people's arms?
Yeah, thank you. So the vaccine in itself, and it's been described to you, is somewhat of a miracle of modern medicine and science. And the fact that we've had it so quick is really showing that, you know, they've been working on this technology for quite some time. But it's very complicated to deliver. It seems simple if you've gotten a vaccine, know that what you see is the syringe and the nurse injecting it into your arm, but that's the end of a long chain of events that occurs in a dance, if you will, and of handoff that has been occurring. So I'm going to start from the beginning. The vaccine itself has to be transported at very cold temperatures from the manufacturer. The two kinds that are out there now, the Pfizer vaccine has to be in an ultra cold condition of minus 70 degrees Celsius, plus or minus 10 degrees. And the Moderna one is minus 20 degrees Celsius. And so what ends up happening is that keeping it cold, and the chain of keeping it cold, is important to make sure that we're maintaining the effectiveness of the vaccine itself. So some very key points that I wanted to make here. We have to monitor the temperatures of the vaccines in the freezers that we have. So we have a system that automatically monitors and reports, and we have to look at it 2 times a day and report on any variances in the temperature of the freezers that it's being kept in. The vaccine is shipped in a special transportation container that's filled with dry ice. The box can be topped off with dry ice, but it has to get kept cold. The vaccine comes in a 5-dose vial. So each vial that we get contains 5 doses of the vaccine. And I'm talking about the vaccine, the Pfizer one right now, does not contain any preservatives. Each of Pfizer's cartons is specially designed container, and it contains 195 vials, which is equal to 975 doses. The thermal shipping containers hold about 5 boxes. So some of the larger places can get as many as 4,875 doses. And it has to be very carefully transferred from the shipping containers into the freezers where we keep it. It can be left in the shipping container for a short period of time, but it has to quickly be moved. So I want to talk a little bit about what happens once we receive it. And I think the reason the ultra cold freezers and the condition that it's in is one of the reasons why, at least early on, the main distribution centers of the vaccines have been hospitals, because they're the places that have the ability to get these ultra cold freezers and keep this. We have other things that we keep in ultra cold freezers, so we have this technology that already exists and the monitoring systems that already exist. So the frozen vials are transferred into a refrigerator. They have to be thawed out for a period of time. It's usually about 30 minutes for temperatures up to 25 degrees to be used immediately. Once thawed, the undiluted vaccine can be stored for up to 5 days in that refrigerator. But you have to, once it's completely thawed and reconstituted, it has to be used within 6 hours. So it's allowed to thaw, the vial's allowed to thaw to room temperature. We mix in to the 5-dose vial about 1.8 milliliters of sodium chloride, so that it becomes the 5 doses that we can give. We don't really shake it. It has to be gently turned back and forth in order to not be disruptive. We have to equalize the pressure in the vials before removing it with a needle, and then it's ready for distribution. And to give you an example of how this delicate dance occurs, in the areas that we're delivering the vials, we have people doing registration. We have people doing check-in. I've got pharmacists who are reconstituting the vaccine and drawing it up into syringes. And then it's handed patient by patient to a nurse who's actually delivering the vaccine into their arm. The CDC has a special tracking mechanism called VAMS, or Vaccine Administration Medication System. And we're using that in the state of Connecticut. Not every state is using that system. The system, what it does is it records the lot number of the vaccine. So I know you've heard that on occasion there have been reactions. We're keeping note of all of that so that the patients wait a period of time. We can tie back any reaction to a specific lot and vial that's been given to that patient. We keep track of what arm it's been put on, the date, the site where the injection has happened, and the system also sends out reminders to patients so that they know when to come back, what time to come back. So I think this whole delicate dance that occurs is part of the reason why you hear that so many vials have been distributed and not as many vaccines have been administered because of the complicated nature of this.
So can we, I'm sorry, I'm like desperate to get into some of the practicalities of this.
Okay, sure.
Where are people going to be able to get the vaccine?
Well, it's interesting that you asked that question. It's been an evolution. What's occurred right now is that companies like CVS have actually been going into nursing homes and delivering the vaccines into nursing homes. They have to transport them in special containers. They have refrigerated trucks that they move it in so that they can deliver it. For the time being, we've been, for the most part, giving the vaccines out at the hospitals. You know, in our hospital, we started out by vaccinating all of our frontline staff, nurses and doctors and respiratory therapists and other hospital employees. We now are administering to first responders. They're all coming into the hospital. Within the next week or so, we're going to be, and with the new administration and really the push to get 100 million doses in 100 days, we're setting up certain systems where we're going to be able to push this out to the community. Beginning within the next 2 weeks, actually starting next week, we're going to be setting up a drive-through vaccination site at Post University where people will be able to come and get their vaccines. But the logistics of setting that up, and particularly then taking it out of the hospital and putting it somewhere else, it's taken us 2 weeks to prepare. We had to get, the vaccinators, the registration staff, engineers to set up the refrigerators, people to point out the logistics of it, the registration of it. So it's very complicated, but we're going to be taking it out in the community. I know that now we've moved in Connecticut to phase 1B, which is people over 75. Within the next couple of weeks, it's going to go to the next level, which will be people between 65 and 75, and those with pre-existing conditions. Really, the technology and the logistics of this has been phenomenal.
The devil is always in the details. We
Yes.
actually have a live question, which is about one such detail. If one lives in Connecticut but works in a healthcare setting in another state, in which state would that person sign up for the vaccine?
They have to sign up for the vaccine in the state in which they live. We're asking people to show their driver's licenses, and people who work in facilities but live in other states need to get the vaccine in the state where they are residents.
Thank you. And just to wrap up this segment, could you talk to us a little bit about what the experience is like when you go to get your vaccine? So sort of what could you walk us through what happens from the patient's perspective?
Sure. So the patients will come, they'll be greeted by a registration person. You have to have an appointment. So we don't, because of the dance that we have and because we don't want to waste any doses, we have it by appointment. So you come, you'll meet with a registration person who will check your appointment and check you in. There's a series of questions that you have to answer before actually being administered about your health that day, any allergies that you have of any kind, because we're concerned about and preparation about any allergic reaction that might have. So you'll be asked to fill out a consent form to get the vaccine. You will then wait in a seat. You'll be administered the vaccine by a nurse, and then you have to wait somewhere around 15 minutes so that we can check and make sure that you haven't had any reaction, any allergic reaction to it, and then you're free to go. So it's a pretty smooth system. The whole experience will take maybe 15 to 20 minutes if you include the registration piece and the 15-minute wait. About 20 minutes in total, 25 minutes.
So that's very helpful to help people understand what to expect when they actually go for their appointment. Thank you.
Sure.
Let's move on to our next segment about the WHO. And I see that we have also some live questions about different demographics and how they might be needing to get the vaccine. So let's go to Dr. Avni Singer and Dr. Banik and Dr. Green. And let's talk a little bit about some of these different demographics, children, people over 65, people over 85, and people who are immunocompromised. Why don't we start with you, Dr. Avni Singer, if you could speak with us about children?
Sure. So happily for us pediatricians, children haven't been a big part of the picture when it comes to severe illness with COVID. And that has also affected the way we think about vaccine policy as well. So just to give you some perspective, maybe 12% of all cases of COVID infection occur in children. So that's not a small number. There are a lot of kids who get it. Most of them have minimal symptoms or no symptoms at all. Kids only accounted for maybe 1% to 2% of all hospitalizations. So even though there's 12+% of cases, only 1% to 2% of hospitalizations. The risk of death in kids is very small, very, very small. So of all kids who get COVID, less than 0.01% may die from it. So very, very small number. Many states who will report this have had no children die at all. And so that's just an important thing. It doesn't mean children can't get, there aren't cases of kids who get more significantly ill, and I can talk a bit about that, but there were happily a small part of the picture. So as a pediatrician, I give shots all the time. It's what I do. I love giving vaccines because I've been doing this since, 1989. And during that period of time, I've seen diseases disappear before my eyes. And it's a very powerful experience as a clinician to be trained and prepared to treat a serious or devastating illness. And then a vaccine comes along and a couple of years later, it's gone. So you just all have to know that that's what's going to happen with this too, if we all do our part and get protected when we can. So that's my general plug for the vaccine. But but for children. So right now, it's not approved for children. The Pfizer vaccine is approved for kids 16 and up. So but it was done in a very small number of kids, and so their sample size was only a couple of hundred kids who were 16 and older. So right now, kids can't get it. The Pfizer and Moderna vaccines, they're both enrolling teens from 12 and up at the moment. And so they're collecting data, and they're starting with the older kids for a couple of reasons. First of all, the older kids are more likely to spread it to other people. That's probably the most important reason. And generally, from a safety point of view, what we do is we start with adults, and then we go to older teens, and then we go to younger teens, and we sort of move down the age range to make sure that everything is being done in a safe way. So the Chinese vaccine, it's reported, the Sinovac vaccine, they have announced that they've proved that it's safe for ages 3 and up, but there's no data published about that, so we don't know about that, and it's not being distributed in the States. Why do we do this by age differently? Because kids' immune systems are different depending on their age. So babies don't respond to, very young infants don't respond to certain vaccines because they have antibodies from their mother's system that block the effectiveness of the vaccine. Different phases of the immune system kind of kick in at different ages. And so kids may get different reactions at different ages. They may need different dosages, and that's being studied too. This is just going to take longer. And generally, the FDA wants longer follow-up times before approving the vaccines for kids. And part of it is because we just tolerate less risk for kids because the disease itself is lower risk for kids. So it makes sense to be more cautious about it. So it is going to take longer. Some people think there's going to be available vaccine for teenagers in the fall of 2021. I think that's somewhat optimistic. For younger kids, it's going to be probably at least another year after that. Why vaccinate kids if the disease is generally mild? So the answer is, number one, some kids do get significantly ill. It does happen. You may have heard about a particular complication called MIS-C, multi-system inflammatory syndrome. Those kids can get pretty significantly ill. They get hospitalized. They tend to do very well. Yale has had a handful of these cases. None of them have died. They've all responded well to treatment, at least locally, but there have been deaths around the country, a small number. And even mild illness in kids is disruptive for the kid. It's disruptive for the family, for the community. So, preventing even mild illness is a worthwhile goal ultimately. And ultimately, from a public health point of view, you really want to get the community, you want to get this herd immunity thing happening. And if you don't vaccinate the kids, you're going to have an ongoing source of spread within the community. So ultimately, it's going to be important to cover kids as well.
Thank you. As always, your words are very reassuring. Dr. Green and Dr. Bannock, could you speak to us about those over 65, over 85, and those who are immunocompromised?
I can start. So with the unbelievable efficacy of 95%, we were very pleasantly surprised that as they were recruiting lots of people into these 2 studies, more than 70,000 people, that they managed to include a lot of different populations, different ages, different race, gender, different comorbidities, and a lot of differences. And what they found when they kind of drilled down is that those in those specific groups actually did just as well as, the older people did just as well as the younger, and those with comorbidities also. I think that at this point, it is recommended for everyone based on who they studied, and Pfizer was age 16 and up, and Moderna is age 18 and up. just a little caveat is that the younger people tended to have more adverse side effects, probably because they had more after vaccination. They had more robust immune systems as opposed to the elderly, but the elderly, when they looked at it, still had very good efficacy. And after the second shot, the younger people tended to have more side effects as opposed to those age 55 and up. So just for people, if they want to know, so at this point, everyone should get it. And especially those that have comorbidities that are a little bit older, because those are the people that tend to have more complications from COVID. I don't know, David, if you want to talk about that.
Yeah, I'll touch on the immunocompromised group also. So, just like Dr. Green had mentioned earlier, this is not a live virus vaccine. So even those individuals who with weakened immune systems would not be at any risk of becoming infected with the SARS-CoV-2 virus from the vaccine. It's not even a possibility. I think the question about different degrees of immunity is something that we're still studying. Some individuals may have a stronger immune response, more durable, long-lasting immune response, and that's something that's going to be important to learn about in the future. But that benefit is going to be there regardless. So, not a contraindication. We know that those groups, those people with comorbidities, people at the older age spectrum, are at higher risk from becoming sick from COVID virus infection itself. So even more reason that they need to be prioritized for vaccination.
Thank you. So I'd like to turn to Doctors Fleischman and Ravski. If you could speak to us a bit about vaccination as it relates to fertility and pregnancy.
Sure.
You go ahead.
Happy to kick it off. First, I just want to start by saying you should all know that my 98-year-old grandmother got her shot already and did well. So if you're 95 or above, go for it. So getting into pregnancy. So this is, certainly a question I'm sure Norman and I can both attest to the fact that I don't think a minute goes by in our day that we are not asked this question and don't get emails and office visits related to this. And part of the reason is that when the FDA approved this for emergency use, the way they worded pregnancy and breastfeeding was sort of not clear. And I would say the way they said it is, we're not going to not allow it, its use. And the reason for that is, unfortunately, pregnant women were excluded from the original trials. And so of the 40,000 people who studied in each of these trials, there were very few pregnant women, and the pregnant women that were included were accidental. So we have very little data on pregnant women and the vaccine. Having said that, both the American College of Obstetricians and Gynecologists and the Society for Maternal Fetal Medicine have come out and essentially also left us with a vague statement. But I think the vague statement is that we do know that COVID in pregnancy, getting COVID-19 in pregnancy, does come with a higher risk than someone who is not pregnant, and that there are increased adverse outcomes such as preterm labor and stillbirth. And that depending on your risk of exposure to COVID, we believe that the vaccine is appropriate for use in pregnancy if the risk of your exposure is high enough, given the concerns about COVID in pregnancy. And I think this is one of those cases where each person, and the reason we're having so many discussions is there is no blanket. If you're over 65, get it. If you're, it's really each case is individual based on the patient's risk. From a breastfeeding perspective, I think Norman would agree. We're all recommending that all of our moms who are breastfeeding, if you're at risk for getting COVID and you're offered it at this phase, you're clearly in a situation where you should be getting it, and we are recommending it for breastfeeding moms. And to put the fertility thing to rest, there early on was some concern that the spike proteins that were created through the mRNA vaccine had some similarities to some spike proteins that do exist during fetal development. And so the concern was that somehow there would be an antibody overlap from the vaccine. That has been clearly disproven in the lab. The spike protein overlap is not real, and there is not enough homology, which is similarity between the two, to really have any concerns that this would in any way impede fertility. So for those women who are planning pregnancy in the near future, we have no problem with you getting vaccinated now. If you have that opportunity, you should do it. And there's no concern or no recommendation to delay childbearing because you got the vaccine recently. I'll let Norman, if he wants to add to it.
So, with all difference, when we do trials, not only do we do human trials, but there's also some animal trials also. And the animal trials, the animal research that was done with these vaccines all showed that there was no adverse effect in either pregnancy or miscarriage rate or abnormalities of the offspring of these animals. Usually they were particularly rats, not that we're rats, but that's always hopeful. What people need to know is that this vaccine is mRNA that you incorporate into your that you get injected. You get it, you put it in your cells. It doesn't go into the nucleus of the cells. It doesn't change the DNA. It doesn't change the DNA of the fetus, of the egg. And all you're doing is making these spike proteins. The mRNA gets degraded very quickly so that you mount an immune response. As Steve said, there's no reason to delay childbearing. If you get the vaccine, if you're trying to get pregnant, you should get the vaccine. If you get the first shot and then you get pregnant, you should get the second part of your vaccine. You shouldn't delay in getting the second part of the vaccine.
So Dr. Ravski, if someone has already had COVID, should they still get the vaccine?
So I'm an obstetrician gynecologist, and if David or Stephanie want to chime in, that's fine. But being a student of history, I can tell you that going back to all other vaccines, Jonas Salk, when he first came out in 1955 with the polio vaccine, showed then that the immunity of the disease is not as good as the immunity from the vaccine. And he showed then that people who had polio, who got polio and got a booster with a vaccine booster, still didn't have as good immune response as people who got the first dose and second dose of the vaccine. So it is recommended that if you've had COVID, that you get the vaccine. You should wait 90 days after COVID because you do mount an immune response. You will, you will get people who don't pass away, who do get better, will mount an immune response. But you want that immune response to go down a little before you get the vaccine so that you can mount a second immune response. My wife just got her first dose yesterday. She had COVID back in April. And I think she's acting like a person getting a second dose, having a little more side effects, fatigue and headache and muscle aches, because she's mounting a response more rapidly.
I think just to jump in, I think that people have talked about waiting 90 days, but I think the CDC still says 30 days. Is that right, Dr. Bannock?
So what the CDC says is the eligibility for the vaccine is you just have to be out of your window where you need to isolate. So the 10-day period of isolation, you need to be out of that. You can wait up to 90 days in order to, when vaccine is in limited supply. So there is that short-term immunity for the 90-day period, like Dr. Ravski mentioned. So you can wait. You have some protection during that time and defer your vaccine for that first 90 days. So I think just to piggyback onto Dr. Ravski's point that the natural infection does stimulate an immune response. There's a lot of belief that it's likely more short-lived and that it's sort of equivalent to if you get your first dose of the vaccine. That sort of primes the immune system to start making some of those antibodies, those B cells, those T cells. But it's that second dose that really boosts that. and really provides both that high level of immunity, but also a more durable, lasting immunity.
Right.
So I think that's the advantage to getting vaccinated, even if you've already had COVID-19.
Okay. And so just to wrap up this segment, we have so many really important questions. I wonder if you could give really brief answers. First, how frequently will we need to get the vaccine?
I'll attempt that question, and I'll say that we just don't know the answer to that question at this point. I think we know that there is a durable immune response, but we only know as long as these vaccines have been studied, which are now, I believe the Moderna vaccine has about 4 months of follow-up so far, and they've shown good efficacy up to that point. But we'll learn more in the days and weeks and months, maybe even years ahead, that this immune response is more durable. But there is a possibility that it may require subsequent vaccines, kind of like the flu, where we get annual vaccines.
Okay, thank you. And another live question. If you could discuss the relationship between the flu vaccine and the COVID-19 vaccine. So if one has not yet had a flu shot, how long do they need to wait before between a flu shot and a COVID-19 shot?
Can I take that?
Please.
Okay. So it hasn't been studied giving the COVID vaccine with other vaccines. So we don't know yet. So the short answer is I wouldn't do it. The CDC and the ACIP, which is the governing body of immunization practices, says they're recommending at least a 2-week interval between either before or after the COVID vaccine. So don't give it together.
Thank you.
And the American College of OB/GYN is saying, because we give flu vaccines and Tdap for tetanus and pertussis, they're saying 2 weeks also.
And thank you. And the last question for this segment, Dr. Avni Singer, if someone had a severe reaction to a vaccine in the past, what's the recommendation on getting the COVID-19 vaccine?
So there's been press about severe allergic reactions, and they've happened, but they've been very rare. The severe reaction that we call anaphylaxis, which is potentially a more dangerous allergic reaction, happens, they say, about 11 times per million doses. So very rare event. If you have your first COVID-19 vaccine and you get a severe reaction, that is a contraindication to getting your second COVID vaccine. If you've had reactions to other vaccines or medications, that's where you're going to need to individualize and speak with your physician, speak with your allergist about it. If you have a known allergy to one of the ingredients of the vaccine, there are these things called excipients, which are the stuff they put into the vaccine to kind of deliver it. One of those ingredients is polyethylene glycol. If you happen to be allergic to polyethylene glycol, you can't get the vaccine. But there's no kind of global answer to this. That's being individualized. So if you have had a severe allergic reaction to a vaccine in the past, you should ask your physician. And for people who have just had food allergies or other kind of significant allergies in the past, they're observed for half an hour after they get the shot, just to make sure they don't react. All the places that administer the vaccines are prepared to deal with severe reactions and take care of them. And those who have had more significant reactions have been treated and have done well.
Important information. So let's move to our fourth and final topic for tonight, life after vaccination. Doctors Green and Bannock, I wonder if you could speak to us about after someone is fully vaccinated, what can they expect their new normal to look like? What will daily life look like for those?
So I'll speak to that at least in the short term, but then I'll hypothesize a little bit into what the long term might look like. But I'm interested in Dr. Green's thoughts as well. So in the short term, for some of the reasons that I mentioned earlier, when you get vaccinated, you're still going to need to adhere to these measures, the protective measures. This is recommended by CDC, all the public health authorities, that even though you're vaccinated, because of some of the concerns about asymptomatic spread in light of others around us not being fully vaccinated and high levels of virus circulating in the community, we still need to adhere to those protective measures. And that includes wearing the mask and the physical distancing, avoiding large social gatherings, these kinds of things that we've been essentially educating on all along since COVID first appeared a year ago. In terms of the long term, I expect, over time, the key factors in my mind are that we need to get enough people vaccinated, that we have community level immunity, and we have to do that to the extent that it drives the amount of virus that's circulating down. So, we may not be able to eliminate it 100%, but it needs to be low enough and we have to have enough people protected through the vaccine to have that feeling of safety to start to de-escalate some of those protective measures that we've been implementing all along. So in the short term, we need to keep doing all the things that we've been doing because of those concerns about the potential for asymptomatic spread. We know the vaccine is not 100% effective. It is 95% efficacy. So there is going to be some small proportion who don't get that protection. So we really need to look for those other metrics like community level immunity and total amount of virus circulating and number of new infections as a way to guide us on what the bigger picture is going to look like in terms of returning to normalcy. So what do you think, Dr. Green? Any thoughts on that?
That was very well done. I totally agree. The only thing that I would add with the increasing variants that are popping up around the world and around the country, we don't know what the vaccine and how protective that's going to be. And we do know masks will protect against every kind of COVID strain out there. So we really need to double down our efforts right now while we're trying to get everyone vaccinated, trying to drive the numbers down, as David was saying.
Exciting to be looking forward, though. Mr. Holtz, I wonder if we could turn to you now to think about anticipating what regulations and requirements in the future will look like for colleges, schools, travel, and large gatherings.
Yeah, I think it's really hard to know for sure. I think we have to see what the experience of the vaccination program is, how many people we get vaccinated. But I would think of this like we think of other vaccines. I know colleges, for instance, require students to get meningitis vaccines before coming on campus and other kinds of vaccines. And I would anticipate that this wouldn't be much different than that. I think we are in a stage now because the vaccine is new and we don't have long-term history with this vaccine, that it's very hard to envision requiring it because of that. But at some point when we have more experience and millions and millions of people have been vaccinated and we really have a better feel for what the long-term effects are, I think those kinds of decisions will get made then.
Thank you. So we have about 5 or 7 minutes left in our program tonight. And I know that all of our panelists, I believe, have themselves been vaccinated. And I wonder, this is open to anyone, if you'd be willing to share what your experience was like with that.
Yeah, I'm happy to share. I had the Pfizer vaccine. The two vaccines were 21 days apart. After the first one, I really had nothing more than a sore arm at the site of the injection. The second one was a little bit more sore than that, but I've had no other of the immune responses or hyperimmune responses that others have had.
Very good to hear. Other experiences?
I had both doses of the Moderna vaccine. And in the first one, I just had some arm pain. Got worse by about 24 hours, and then all of a sudden it went away. I had my second dose yesterday. And last night I was feeling arm soreness, and then I got some chills, but a couple of blankets, a good night's sleep, and I woke up and came to work this morning. I'm still here. So,
I thought you looked a little different though, Norman. You okay?
Yeah.
I'm glad to hear.
I got mine on Christmas Day. There's not much else to do on Christmas Day for me. So I went and got my Moderna shot, and I have my second shot tomorrow. other than a sore arm that did not restrict my ability to play tennis the next day, so it was fine. And I'm assuming tomorrow will go just as well.
I mean, you don't play tennis well to begin with, Steve. So.
Thank you.
I had the Pfizer shot, and I had, after my first one, I had a little bit of a headache, and I felt a little under the weather, and my arm hurt a little bit. And the second time, I had all the same stuff, except a little bit more, and I really had kind of chills and felt kind of yucky enough to need some Tylenol for about a day, and then I was fine. And and every time I felt lousy, I thought, this means my immune system is really doing its thing. So I think it's great.
So I had the Pfizer vaccine, and I had the opposite experience. After the first dose, I didn't have any symptoms, and I was very disappointed that I didn't have symptoms because I was afraid I got the placebo or something. But after the second dose, I did have some arm soreness, a little bit more than I would expect to have with like a flu vaccine, but it was completely gone within maybe like 8 or 10 hours, and otherwise I felt fine.
So yes, go ahead.
I had the Moderna and just some arm pain as well. And I'm getting my second one tomorrow. And it was this was way better than the shingles vaccine, which laid me out for 2 days. So you have to expect all these side effects and welcome them.
I had the Pfizer vaccine for both doses and had very little reaction except for arm pain. But just a feeling of overwhelming joy.
As a personal note, Dena, I'll tell you, my father-in-law passed away from COVID in April. And so the discomfort and the chills and the pain is better than getting COVID.
100%, 100%.
It's definitely worth it, and it's good to protect yourself and your family and the community. And that's really the bottom line here.
100%. And of course, we're so sorry to hear that. And it sounds like everyone's experience was nothing that couldn't be handled with some over-the-counter medications and some blankets and some rest and relaxation. So that's
chicken soup.
And chicken soup. Very good to hear. Yes.
I just add one other thing.
Yes.
In my role in the hospital, I do have to speak with many employees and encourage them all to get vaccinated. I've spoken to hundreds of employees in our place, and many have reported nothing more than the symptoms that everybody on the panel has said. And I really do feel that there's an overwhelming sense of exhilaration about this and doing our part, because we all have to contribute to the herd immunity that we need as a country. And everybody participating in this is just so important.
The other thing is that there's a website called vSafe that you automatically get signed up to, at least in Connecticut, where they track you and they keep sending you emails. How are you feeling today? How are you feeling today? After a week, once a week, how are you feeling? So that they will get data in what happens to everybody who gets the vaccine.
So for our last question tonight, a really important one, people would like to know when they will be able to hug their loved ones again.
I'm not a good person to ask. I've been hugging people. I'm sorry. I'm a hugger by nature, and I've been hugging my loved ones from the very beginning. So I feel a little better now that I'm vaccinated. But
would anyone else like to respond?
So, I think, when we think about moving towards, the whole concept of safety, when is it safe? When are we safe from everything? I think we take incremental steps, right? So, when you become vaccinated, that is some safety. When all those around you become vaccinated, that's moving the needle a little bit further, making you a little bit more safe. We're going to get to the point where it's going to be safe to do all these things openly without needing to worry, but, we're not there yet. So each of these interventions, every time that you get vaccinated, every time those around you get vaccinated, it just moves us a little bit further to that new normal, to that feeling of safety and security when we're interacting with each other. But it's going to take some time. we need everyone to get vaccinated, or as many people as we can to get vaccinated. We need that level of virus to come down, but we'll get there. It's going to take time, and I think you have to look at your own circumstances. The protection that you have, the protection that those around you have from vaccination, and you need to make that decision for yourselves. And until we get to that point of absolute safety where there isn't COVID, we're going to keep moving that needle and get closer and closer every day.
Well, those are some uplifting words with which we can close the program tonight. We've covered many topics, and I hope that everyone is able to leave this webinar feeling more knowledgeable and prepared to make decisions around COVID vaccination. I want to thank all of our panelists for taking the time to participate in tonight's program and for sharing your expertise with us at such a critical time. We really appreciate your stepping up, both in your professional capacities and as members of our Jewish community. Thank you so very much. And thanks to all of you out there in webinar land for participating tonight and for submitting your excellent questions. We are truly all in this together, and I hope that this webinar brings us closer to being together in person soon. Thank you, be well, and good night.
Good night, everyone.
Good night, everyone.
Good night.
Good night.